in terms of ischemic stroke risk stratification, the initial studies, more recent phase 3 studies of direct oral anticoagulants, they were done between 2006 through 2011. Back then, they didn't use this risk stratification criteria called CHADS2 score. They did not. Most of them, they mandated a certain age and presence of one or two other risk factors in addition to atrial fibrillation. But 1/3 of patients enrolled into apixabans and dabigatran's phase 3 randomized controlled trials had actually a risk score of 0. So they were very low risk patients. So CHADS2, the score that's called CHADS2 has been used. It's like a 6-point scale that relies on age over 75 and presence of prior ischemic stroke, hypertension, diabetes. So yeah, you add up the points and it goes from 0 to 6. Another group came up with a new score called CHADS2, which is currently commonly used in the field of embolic risk stratification in patients with atrial fibrillation. And it added presence of vascular disease, such as coronary artery disease or carotid artery disease or peripheral vascular disease, presence of heart failure to the equation. And it goes from 0 to 9. So right now, the current guidelines recommend using CHADS2. And if a patient has a CHADS2 of 2 or more for man, 3 or more for woman, then the US recommendations is to start this patient on anticoagulants. And if there is any concern about long-term anticoagulant use, then the recommendation is to consider left atrial appendage closure. The problem is that these risk scores, they have nothing specific for atrial fibrillation. These are essentially a bunch of risk factors put together. And for that very reason, they don't do a very good job in terms of predicting individuals' risk to develop an ischemic stroke in the setting of atrial fibrillation. There are some new approaches using echocardiography or using cardiac CT or cardiac MRI. One can look for enlargement of the left atrium. And more importantly, the shape and size and even angulation of the left atrial appendage. These things provide a lot of information. So adding imaging data can certainly help one to better stratify the risk of embolic events in patients with atrial fibrillation. When it comes to hemorrhage risk, brain hemorrhage risk especially, we have a lot of markers. So presence of microbleeds on brain MRI, presence of moderate to severe white matter disease or white matter hyperintensities again on brain MRI, presence of a high number of enlarged perivascular spaces on brain MRI, presence of lacunary infarcts. All of these things have been associated with a higher than usual brain bleeding risk. These are all also markers of brain small vessel diseases, such as hypertensive brain small vessel disease and cerebral amyloid angiopathy. So presence of any of these MRI markers should lead one to reconsider lifelong use of oral anticoagulation and should lead to a discussion with the patient and family whether they would like to consider left atrial appendage closure, which requires only 6 weeks of anticoagulation, after which it's just oral antiplatelet treatment.